Good afternoon. Hello to everyone. Guess what time it is? It is 4 o'clock in the mountain time, which means 6 o'clock on the East Coast and 3 on the West. And there is only one thing that we all do on Tuesday afternoon at this point, and that is Fertility with Fink and Friends. I am Fink. You are friends, and I am so happy to see everybody joining me in here on we've got a Facebook stream. Let's see, we've got a Facebook and a YouTube and a LinkedIn right here. And we've got a couple of different Instagram feeds. We've got mine over here. That's Randy Fink MD and CNY Fertility over here on this side. So happy to have everybody. My name is Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado Springs. And I am also the medical director at the Miami Center of Excellence in beautiful sunny South Florida. But I live here in Colorado and have had the beautiful opportunity to meet so many wonderful people this week and see so many great folks just going on around their journey. And I hope you had a chance to take a look yesterday at the post that I made on my Instagram. Actually, we put that on CNY's Instagram as well, talking about Thanksgiving and just about kind of trying to be thankful for the little things and having to just live with the stress of what we're doing and how sometimes it feels so hopeless. And so difficult to go through this process. But the little things make all the difference. And I used a couple of examples in my post there about, watching the sunrise and cuddling with your pet. I have a dog and 4 cats, and fortunately, they all love to snuggle, and it's really a wonderful feeling. A smile from a stranger or a text from a friend just to say hello when you weren't really expecting it. Those are some little things. I wonder what kind of things make you happy. What sort of things are those little things that you have thanks to give for this year? I'd sure like to know if you are interested in sharing it. Meanwhile, let's see who we've got. Beautifully, LOCD42 was our first to join over here. Hi, Carly. Carly is with us on the CNY side, who had a very big day yesterday. We're keeping our fingers crossed for you, my friends. Over here on mine, Alyssa7766, Nurtured Shanna, who has a wonderful does some wonderful posts there. Bree Bales, hopeful in 2023. We've got Facing Destiny. My friend Amber Vince from the beautiful state of Kentucky is on board here. BJ Pumping, Jody O. Allison. Allison. Hi to Alyssa. The Salyastio clan is with us here. And let's see what else we've got on the CNY side. Being Shar, Graceful Journey, Talented Hands. Hello, nice to see you today. Haley Kavanaugh is with us, and I hope you too have a great Thanksgiving. Thanksgiving's just around the corner, and I hope you're looking forward to eating as much as I have. Ovi Mercy says, do you think it's too late to take the flu shot because Thanksgiving is on Thursday? The answer is no, it is not too late. In fact, I hate to say it, I have not done mine yet, but I intend to do it. I may actually go do it this evening. It is not too late to get a flu shot, so please do think about doing it. I'm one of those people who actually, I have to tell you, believe what you will about vaccines and so forth, but I'm one of the people who probably lived when I should have died because of a flu shot one year. I got something called meningitis, which is an infection in the brain, which explains a lot to you now, right? Doesn't it? That really had entirely to do with the influenza. And I said, well, good thing I got the doggone flu shot here. And the infectious disease doctor said, I don't think you understand. If it weren't for that flu shot, you might very well be leaving this hospital in a box. So I am a believer. Hi to Tiffany over there on the Facebook side. Glad to see everybody. So the first question I want to answer is, and I would like to talk about puppy cuddles. That would be a nice thing, Shanna. Yeah, I think that's a way better thing to talk about. But, I got a question from a very dear friend of mine who is going through some tough times with through the IVF process, and I wanted to talk about a couple of little things that maybe are things that you have faced as well. So she did an embryo transfer and of a euploid or a tested embryo, and unfortunately resulted in a biochemical pregnancy. And I just have to say that like having any kind of miscarriage, a biochemical pregnancy is cruel and unusual punishment, as I have said before. So I wish it were something that was something that none of us really had to deal with, but it is a reality. A biochemical pregnancy is an embryo factor. It's something that happens when there's an embryo problem. The embryo implants and starts to grow until the body realizes, well, wait a minute, there's something wrong here. And the hormone levels start to come down before there is ever a clinical pregnancy, meaning to say something that you could see with an ultrasound inside the uterus. So you get that positive pregnancy test, you are ecstatic about it, and then the number starts to go down. As crappy as a thing as that is, I do think that there is some silver lining there. Because what we know about a biochemical pregnancy is that this is an embryo issue. It's not a mom issue. In fact, quite to the contrary, what it tells us is that the brain was talking to the uterus and the uterus was listening. And as a result of that, the pregnancy figured out how to implant. That means that everything works right. So, as much as it is a loss that the embryo itself didn't continue to grow, it tells us that the system is working. And that is something to give thanks for, because it means, holy cow, now we know that this works. Now we know that that uterus can carry a pregnancy, can implant a pregnancy. It's just a question of getting that pregnancy to grow, and that's an embryo issue. So there is a little silver lining there. Now, it's not always so silver when you're out of embryos and you have to go through the process again, but at least it means that we know there's something good on the horizon. Now, in her situation, she has what's called a mosaic embryo that's left over. So the next transfer is going to have to be of an embryo that is considered to be a low-level mosaic. There are some clinics that will tell you to dispose of your mosaic embryos. They will say that embryo is no good, you cannot transfer it, so forget about it. And I would say, that is a terrible thing, and it is not accurate. So what we know is that a mosaic embryo. So, when we're doing the testing for PGT, they're biopsying from the portion of the embryo that becomes the placenta, right? It's not actually taking a piece of the baby, it's taking a piece of the placenta, part of the outside, what becomes the outside part of the whole baby apparatus. Well, when you take that piece, it's possible that you can have something that looks abnormal in the placenta that's actually completely normal in the baby. And that's why there is a false positive as well as a false negative rate on the PGT testing. It's just not perfect. But what a mosaic means is that instead of having two sets of normal chromosomes like the rest of us do, there is one set of normal chromosomes and something that's abnormal in one set of that chromosome. Now, what does that mean? Well, it means that it's probably just part of the placenta. With a euploid or a tested normal embryo, we have about a 60% probability of getting pregnant with that first embryo transfer. By the time we do a second transfer, it's about an 85% probability and pretty close to 95% by the time of a third transfer. Generally, we tell folks you want 2 euploid embryos for every baby that you hope to have. Well, 60% is the number that we look at for a euploid embryo. if it's an untested blastocyst, a day 5 embryo, then we know that that embryo has about a 30% probability of getting us pregnant. So 60%, 30%. Guess what happens with that mosaic embryo? It's about halfway between. Well, not exactly halfway, but it's roughly about a 40% probability of getting pregnant. And if that embryo does stick, it is nearly the 100% probability that it is as normal as the euploid embryo that you were going to transfer. So if it sticks, it's not going to be a baby that's going to give you a birth defect or something that's wrong with it, something that you have to fear, something that you have to worry about. So that's pretty good. It's still better chance of success than an untested blastocyst. So I am always sorry when folks have to go through either a miscarriage or a biochemical pregnancy. But on the plus side, it tells us that things work the way they're supposed to. It's just an embryo issue, and that low-level mosaic embryo is not one to discount, because I can tell you every single week we have folks who have normal babies because of their mosaic embryos. So we're always happy to talk to you about the reality of those mosaic embryos. If you call the genetics lab, oftentimes, they may poo-poo it because they are worried about somebody wanting to sue them or something for, potentially telling you to transfer something that they said was not a normal embryo. They will not always give you the same information that your doctor will. So happy to talk to you about that. Fingers crossed, Amanda. I know that there are happy times in your future. All right, let's see who else we got here. Hi, Skittles. Hi, Al Higgins and Alexis in Miami. Hello to my dear friend. Well, we'll say NY Baby DJ. Hello, NY Baby DJ. All right, let's see what else we got here. We've got questions coming in. Let's see if we can answer some of them. Tiffany's asking about, is an AMH of 1.48 a good number for a 31-year-old? And I would say that yes, that is a good number. AMH is, of course, the anti-Müllerian hormone. That is the measure of ovarian reserve, and it tells us how well we expect that you might respond to stimulation. When that number is less than or equal to 0.03, essentially that means that there are no eggs remaining in the ovary, or eggs that, very few, enough that it's going to be very, very difficult to get you to produce them. So 1.48 is very good. You can look, actually, if you like, at Google and look at AMH by age, and you will see a graph, a curve that shows you kind of where the 50th percentile is, the middle of the road, as it were, for AMH level based on age. And that is a very interesting thing to look at. As it so happens, Brandis and I this coming weekend are doing it's a little festival where we will offer that AMH testing for people and be able to do a little bit of counseling about what that means, because AMH is one of those things that every woman should know what her number is, because you may find that it's lower than you expect, which means the clock is ticking. And maybe in that scenario, you think about doing some egg freezing, or think about, we were planning to get pregnant next year. Maybe we want to start right now. Having that information is very, very valuable. So if you don't know what your AMH number is, I would encourage you to get that checked. Oh, let's see. Morgan is here. Morgan is wishing everyone a happy Thanksgiving from the Facebook side. Thank you. And Tiffany is looking forward. This is Tiffany Glassford, looking forward to meeting the staff in Buffalo. Oh my goodness, Jen Ladaga is here with us on Facebook and is welcome. They will be soon welcoming their rainbow baby. So that is fantastic. Tiffany's asking about a low AMH. The AMH is 0.05. Can you still do IVF with that kind of number? And the answer is, at CNY, yes. There are some clinics that are very concerned with their outcomes. And so they will say, well, the odds of you being able to conceive with that, you're going to have to go through a lot. They're so expensive. They don't see you doing it. So they don't even want to count you in their numbers. So they may try to turn you away. At CNY, we do accept everyone because, yes, it is possible to have a baby through IVF with an AMH of 0.05. You just have to know it's an uphill climb. It's a battle to get there. It takes a little patience. But yes, it is possible. It is also possible to get pregnant on your own with an AMH of 0.05 because that number really only tells us about how we think your body is going to respond to the stimulation medications for IVF. Doesn't say anything about your fertility at home. So Tiffany, best of luck there. Let's see if we can get to some of these Instagram questions. OV Mercy, is it too? Oh, we talked about that flu shot. Yeah, we did. Sorry about that. Skittles is thankful for the opportunity to be able to afford fertility treatment. Because I did ask that question, what are you thankful for this year? If you think about wanting to throw your answer in, I would love to share that with our group here. Let's see, is it a good idea to do an FET in December end or January start? I think that there is no problem with that. So CNY is going to be closed on Christmas Day and New Year's Day and Thanksgiving Day. But we are open half days on Black Friday, so it should basically be a regular work day. And the same thing with Christmas Eve and New Year's Eve. As far as cycling goes, I think it's a perfectly fine idea. That comes from Rakenahar, if I'm saying it right. So, OV Mercy is also thankful for God's mercy and for giving a good report over a scare of testing. Well, that's true. Testing is not a perfect thing, and so it is great to always get that positive report. Okay. Haboshali, 90. I had my transfer on Tuesday, the 14th. The next day I used the stairs instead of the elevator. Do you think it will affect implantation? I am scared. No, you can live a normal life after implantation and the steps are okay. I tell people, what I usually say is, listen, I don't want you doing anything that's crazy. I don't want you doing anything that's overly strenuous. Alligator wrestling, skydiving, mountain, rappelling down a rock face. Let's see, what else? Extreme skiing, helicopter skiing, that's extreme snowboarding, bad idea. But pretty much you can otherwise live a normal life, Haboshali. So no, I don't think that taking the steps instead of the elevator hurt you in any way. In fact, maybe it just helped your heart a little bit. Okay, L. Higgins, 2 failed embryos, two failed transfers with PGT, tested embryos. I had a hysteroscopy to remove 2 small polyps, and now on the immune protocol, and we'll do a modified natural cycle in January, praying this one will stick. Well, we are here with you, my friends. I really do believe in the modified natural cycle. In the medicated cycle, we're giving you all kinds of medication, trying to take over for what your body naturally does. And when we give you all this medication, it shuts down your body's ability to make most of that hormone on its own because we're giving it all to you. We are really trying to control every last variable. In a natural or a modified natural cycle, we're letting your body take the lead. Your body makes these hormones anyway. So why do we need to substitute that for artificial hormones when your body is going to do it yourself? And there are many studies that tell us that the outcomes from that modified natural cycle are even a little better than the medicated cycle. So when you talk to me for a consult about why your transfer was unsuccessful, I will probably want to talk to you about a natural or modified natural cycle because I do think that the evidence shows us it's a good thing. Shanna is feeling nervous but hoping for good news tomorrow. You transferred your final 2 day 3 embryos. Tomorrow is beta day, so God bless Shanna. Fingers crossed. Hi to M. Afer. Um, let's see. Baselines for first transfer tomorrow for Fit and Healthy. Fit and Healthy 26 to be precise, right? Do you recommend an HCG wash? And if so, how many days before transfers? I hear it can cause some fluid to build up in the uterus. I got a question over here from I think it was on the Facebook side as well. I thought I saw it. I'm not seeing it at the moment, but maybe it was from one of the Instagram pages, and it said, why do the HCG wash? So what is an HCG wash? HCG is the pregnancy hormone, and when we put some of that pregnancy hormone inside the uterus, it causes the lining of the uterus to kind of turn on. It increases the production of some of the proteins that are associated with pregnancy implantation. So it can increase the probability of pregnancy. I feel pretty good about recommending an HCG wash. There was a small study that came out looking at doing that HCG wash at the time of transfer. I am not a fan of that for several reasons. One, because there was a very narrow window during which that transfer had to be, or rather, during which the wash has to be done with the transfer to follow it. The question of really just a few minutes, and that may not be realistic because embryos have to come from the laboratory. They have to be brought to us. They have to be prepared. So doing it according to the timing that was associated with that study, really, honestly, it's not realistic. So I don't recommend that. Additionally, we're putting fluid inside the uterine cavity, which is something that we don't want too much fluid, maybe a little bit, but we don't want a lot of it there. Because we need that embryo to be sort of sandwiched and sponged it's a nice spongy, warm, juicy place for the embryo to implant. And if there's extra fluid in there, well, you can think of it as like that sponge. It's too much. There's too much fluid. So that's the reason that I don't support that. Doing it on the day of transfer. I prefer to do it the day before. Now, that volume is usually gone by the time of transfer. If there happens to be a bunch of fluid there at the transfer, then that's something that we would look at. But typically, of all the people who have HCG washes and in all the transfers that we do, at least here in Colorado, which may sometimes anywhere from 15 to 20 transfers in a day, I don't see fluid that builds up there, or the fluid that's still kind of getting stuck there from folks who have had an HCG wash. So feel pretty good about that one. Fit and Healthy, do it the day before. Alex knows his gun. I like that name. Can I get an egg retrieval the same month I get vaccinations for travel? Yes, you can. So there is no known harm to vaccinations as it pertains to egg quality or for an egg retrieval. But common wisdom might suggest, I think a flu vaccine is fine, but as far as vaccinations for travel, it does cause kind of a big immune response. And what sort of effect is that going to have on your ovaries? I can't say. I don't know. It hasn't really been studied very clearly, but I would say if you have the opportunity to wait on the travel vaccinations until after your egg retrieval, that to me would probably make more sense. All righty. Oh, I see. And is it a good idea to do an FET at the start of January in Colorado because of snowstorms and winters? Well, in Colorado, believe it or not, the winter here in Colorado Springs is pretty mild. The joke is, and you might have heard me say this before, that it might snow in the morning and you could be playing beach volleyball in the afternoon. So when it snows, it typically doesn't stick around on the ground for very long here. We are at a high elevation, but we are not by the ski resorts. That's a couple of hours from here. And so I think it's perfectly fine. We are open every day. Even when it snows. I say open every day, except for those holidays and on Sundays. But snow doesn't slow us down. Let's see here. B Voyager said, my doctor recommended Lupron due to endometriosis, but I don't really have pain. What are the thoughts on Lupron? Well, that's a very good question. So, presumably, you have been diagnosed with endometriosis. And when you have endometriosis, then what we know is that that endometriosis can affect the lining of the uterus such that it can prevent an implantation. It causes the secretion of an inflammatory protein that is known as BCL6. And we can actually test for BCL6 with a test that's called Receptiva. And that's one of the things that we do talk about in folks who have had recurrent implantation failure when their transfers aren't working. We kind of want to look at, well, why not? One of the things that we'll test for is the presence of endometriosis. That can be done through a laparoscopy, or it can be done by testing that uterine lining. Well, when you are positive for that protein that's called BCL6, what we know is that your probability of being able to implant an embryo drops to less than 10%, unless we suppress that endometriosis and really turn off the production of BCL6 for 60 days. There are a few different ways to do that. Lupron is one of those ways. Lupron is a big old sledgehammer. It shuts down everything. It puts you into a temporary menopause. There are some other medications that we can use instead. There are oral medications that are much better tolerated. One of those is called Orilissa, and the other is called Myfembree. Myfembree is my preference because you take it once a day, as opposed to Orilissa, which is designed to be taken twice a day. These will turn off the production of BCL6, and that very first cycle after doing your suppression, your success rate from an embryo transfer goes up to greater than 60%. So yeah, it does make a difference. Again, Lupron, not my favorite because of the side effect profile, but there are other options, B, and I hope you'll look into that. Princess Fefe says, things to give thanks for taking care of my patients in their most vulnerable moments. Princess there is an oncology nurse, and God bless you for the work that you do. I think the two groups of people who are unsung, well, there's so many unsung heroes, teachers and first responders, but oncology nurses and pediatric nurses. Thank you so much, Princess Fefe, for what you do. Over to the Facebook side, what are my thoughts? This comes from Chloe on IVF and type 2 diabetes. It's perfectly fine. We want to have your hemoglobin A1C, which is the long-term measurement of your blood sugar. We want to have it really as normal as possible, both at the time of egg retrieval and at the time of embryo transfer, because both those things, so egg quality can be related to controlled versus uncontrolled diabetes, and the risk of miscarriage and birth defect as that embryo grows is directly affected by the overall blood sugar levels and where your blood sugar has been. The hemoglobin A1C is a simple blood test that really is a reflection of what your blood sugar has been over the last 90 days. So it's something that really every diabetic person with diabetes should know. But as long as you are in reasonable control there, Chloe, no problem with type 2 diabetes. Morgan is telling us to be thankful for living at a time when fertility treatments are available. Well, that's very true because, when I was a kid, that it wasn't a thing, and in fact, even early on in my training, it was only sort of just becoming a thing. We've really come so far with fertility treatments, and it's such an honor to be able to offer them to nice people like you. Robert is here. Hello, Robert. I am, actually, Robert and Desiree, it looks like. I'm 41 with one fallopian tube. I have a good egg reserve, but have had 2 failed IVF cycles. What can I change for my next cycle? Well, I'm not sure what you mean there by failed IVF cycles. Does that mean that you made an embryo, but then and you put that embryo back in, you did a transfer and it didn't stick? If that's the case, then really the most likely culprit in that scenario is age, because as you know, as we mature, it becomes harder and harder to get pregnant, right? And why is that? Because the DNA that's in our eggs becomes less stable. And so it's harder to produce an embryo that's normal, which means it's harder to produce an embryo that will stick. So that's the most common reason. And especially at 41, it's really a numbers game. It's about getting, maximizing the number of eggs so that you can maximize the number of embryos so that you can really maximize your options. So glad everybody's here with me today. Fertility with Fink and Friends. I am Dr. Randy Fink. It's about 31 minutes or so after the hour. We'll be here for about another half an hour. So let's see on this week of Thanksgiving if we can't tell us all, if you would, what you are thankful for, and let's see if we can't answer some more questions. This one comes. Oh, where did that go? Noemi, oh gosh, I just want to thank you, Dr. Fink. Stop. Okay, one more time. I want to thank you, Dr. Fink. You did my initial consultation, and even though I had to do 2 retrievals, 2 FETs, and 1 fresh transfer to get my baby, your wonderful bedside manner stood with me throughout my journey. Noemi, thank you. Gosh, what a beautiful thing to say. I sincerely appreciate that. Thank you. Thank you very, very much. Michelle is here on the Facebook side. I want to start my fertility journey in January. I've been having issues with thyroid, hypothyroid, but it's getting better. What should I focus on to get my hormones right? I am 43 years old. Well, 43 years young, my friend there. So the first thing is thyroid. We want that TSH level. The TSH is the thyroid stimulating hormone, and it is a reflection of where your thyroid is in terms of its volume knob. We want that to, and the way the TSH works is that the higher the number, the lower the thyroid function. The lower the number, the higher the thyroid function. So if you are hypothyroid, is your TSH level going to be high or low? It is going to be high. That's right. So we want that TSH to be between a 0.5 and a 2.5 in order to be optimized for fertility. What does that mean? The evidence shows us that when those numbers are, in that range between, and let's say that your number is a 2.9, doesn't mean that your thyroid is abnormal. In fact, that's considered to be the normal range for the thyroid hormone, but for fertility between 0.5 and 2.5. And that's the reason that we check that thyroid hormone whenever we are starting a cycle. There are some supplements that you can take that help with egg quality. I'm happy to send you that list. You can message me at Randy Fink MD. And I will apologize. Some folks have messaged me and I haven't been able to answer back yet. We've been real busy over here leading up to Thanksgiving, but I will happily send you the list and can even put a discount code on it for you so that you can get a discount. Discount is always good. So best of luck there, Michelle. Chelsea's asking, would you recommend transferring 2, 3, 6 frozen embryos at the same time? I'm 32. So Chelsea has some day 3 embryos. And she's talking about what the grade of those. Now, technically, we don't really grade the day 3 embryos, but there is a marker that sort of tells us whether they are poor, fair, or good quality. Those 3, 6 embryos are good quality embryos, Chelsea. The guidelines that we follow would recommend that you would transfer 1 of those embryos, particularly on your first transfer. Now, if you've had transfers before, 4 and you weren't successful with them, then it's certainly not unreasonable to think about transferring more than one embryo. But we want you to have one healthy baby at a time. And this is something that we talk about all the time here because folks oftentimes will come in and say, well, I just want to have twins, or I would love to have triplets. Let me just get it all over with. That's not a good thing for you as a mom or for the babies, because it is virtually guaranteeing a preterm delivery and dramatically increasing the risk of both pregnancy loss and significant complications, including things like cerebral palsy. So we really want you to have one baby at a time. And when you've got more than one embryo there, 2 embryos can still split and become 4. 1 can split and become 2. 4 embryos can split and become 8. And oh my heavens, we don't want to read about ourselves on the cover of the National Enquirer, do we? No, thank you. Okay, what else we got going on here? Shanty Dib says, what do you think about fertility tea? Is there a way to choose who's going to do the transfer? And a happy Thanksgiving. So fertility tea, we offer, as do all the CMY locations, offer acupuncture. Traditional Chinese medicine at the time of embryo transfer. There's you can do a pre and post transfer acupuncture treatment, and I really do believe it makes a difference. Acupuncture, when studied, some studies show that it doesn't do a whole lot, but many studies show that it does. So I'm a believer, and I do think that there are some herbal therapies that make a difference. And it depends on what's in that fertility tea, because again, there is a well-researched trove of information on what supplements can do to help human fertility. So do I think fertility tea is helpful? It certainly can be. Is it harmful? Probably not. So does it taste good? That I don't know. If it's disgusting, maybe you don't want to do it. So, I will tell you that there's a place for herbs, herbal medicine in fertility, and also in general obstetrics, in terms of trying to get the cervix more ready to open up. Red raspberry leaf tea, evening primrose oil. These things are cervical ripening agents, and so so I'd be cautious about what's in the fertility tea, but yeah, I think it can't hurt. Yes, well, in Colorado, really in most of our locations, if you have a preference of who you would like to do your embryo transfer, as long as we are in the building, we are generally happy to do that. Sometimes it's not possible if we're stuck in the operating room, or if there's some other issue going on, some other fire we're trying to put out, that we may not be able to get there if it's a day that one of us is off. But let's say that I am doing transfers and you really wanted to have Brandis, then you ask, and she's generally very happy. We're all very happy. I believe the same really holds true in the other offices as well. I know it does in Syracuse. I believe it does in Albany. There's only and probably the same really in Sarasota now as well. So yes, I do think so. Okay, let's see. Style Yourself had an embryo transfer 2 weeks ago, and then you cut off. I don't know what happened 2 weeks ago. Means you're probably pretty close to having that pregnancy test. So fingers crossed there. This comes from Kate Mitz. What's the difference between a day 5, a day 6, or a day 7 blastocyst when it comes to success? So what that means is that as an embryo continues to grow, it goes from being what's called a cleavage stage embryo, where it's just really trying to figure out how to divide and how to stay alive and how to keep growing, to then it becomes what's called a morula, which is an intermediate step, and then finally a blastocyst. And the blastocyst means it has formed itself into a little machine. It's got a whole chemical system that's working, a whole functioning little bit of machinery. That's what a blastocyst is. Typically that happens by day 5, but sometimes it can take a little bit longer depending on how quickly the embryo is growing. It can be day 6 or it can be day 7. A day 5 blastocyst will always give the highest pregnancy rate, although there is not a huge difference between a day 5 blast and a day 6 blast. There is a bit of a difference between a day 6 and a day 7. So if you have a very highly graded day 7 embryo and a not as highly graded day 5 blast, we're still probably going to recommend that you do the day 5 embryo first because they will usually have a little higher success rate. Let's see, what are the LH and FSH values for a cycle? This comes from BJ Pumping. I'm not sure what you mean there. Why do we test them? Well, when we give you the medication that we use for stimulation is FSH. And so we want to know what your FSH level is when we're starting, because if your FSH level is too high, your brain is already making a lot of FSH in order to try to get eggs. So giving you higher doses may not make a big difference. LH, or luteinizing hormone, is something that shows us when you are getting ready to ovulate. And it also has to do with some egg maturity issues and the egg development. So these are things that we check during the cycle. Hopeful in 2023 asks, is the HCG wash 2 days before the FET still as good as the day before? Yes, it is. In fact, CNY's protocol is 1 or 2 days before. That's generally what we offer to people. So even if you're doing it 3 days before, I think you're doing something that is better than nothing. I don't think there's a problem to do it 3 days, and sometimes it has to work that way because of weekends or holidays or staffing problems. But in general, a day before, 2 days before, even 3 days before for an HCG wash, I think is okay. Hi to Grace and Brock Tongue. Glad to see you both here. And my friend Angela is with us. Miss Angelina, it's very nice to see you. Actually, I don't see you, but you see me. So thank you for being here. Brandis threw in a bit of an opinion here. Agreed with the same day HCG wash. Prefer the day before, not the day of. I will tell you that day of HCG wash is something that really speaks to the power of social media, as it were, because people out there started talking about doing this HCG wash on the day of retrieval, or rather, I'm sorry, on the day of transfer. And it spread like wildfire. Lots of people were coming in asking for it because 1 or 2 people said, oh, you should do this. There's a study that shows it helps. Well, actually, we studied that. We studied it specifically at CNY in Syracuse, and we found that the pregnancy rates were lower when doing the HCG wash on the day of transfer. So in our own system, strongly really recommend against it. All right. Thank you for indulging me in that. Care 1513 or Carrie, I'm not sure. Hello. I was prescribed Depo-Provera for 3 months to suppress my endometriosis after my laparoscopy. Does it help just like Lupron or Oralisa? Well, not really. So, I mean, maybe, maybe you did it. I would say yes, that is considered suppression. And I think that you're fine then to proceed with an embryo transfer if you're ready to do so. But I wouldn't recommend Depo-Provera as a first-line treatment for people of reproductive age who have painful endometriosis and you have surgery. Well, most of the people after a little time on Depo-Provera kind of stop having periods entirely. So it may have a big effect on the pain aspect of endometriosis, but the other ones are just better studied. And the other problem with Depo-Provera is that once it's in your system, it tends to last for a while. It's designed to last for 3 months, but sometimes it really does just hang around a lot longer. So best of luck to you. Thankful for Dr. Arroyo, Dr. Kiltson, most important, my body and how it's been responding to my IVF treatments. Wow, that's fabulous. This comes from Mayfer or Mayfer. I don't know how to say it. Thank you. But thank you for chiming in. I will have my 3rd retrieval Friday at Syracuse. Friday is going to be a good day for you, my friend, and all the best. And thanks for sharing. What are you thankful for as we approach this Thanksgiving? I sure want to hear it. What else we have? some other questions here on the Facebook side. If you have one fallopian tube blocked, this comes from Michelle, can you do something to unblock it, or is that even worth it to try? The answer is nah, I wouldn't do it, because having one fallopian tube working or having one fallopian tube blocked is really the same as taking one of those tubes out. Your fertility is really barely affected by having only one fallopian tube. So to have to go through a procedure, a surgery is really what it would be, to try to unblock one single fallopian tube that's blocked when the other one is working, is really not worth the effort. Because the other problem that you run into there is that if you're able to get that one tube open, it's going to significantly increase your risk for an ectopic pregnancy or a tubal pregnancy. So I would say, no, Michelle, I don't do that. Let's see. Allie Smith asks, I had a subchorionic hemorrhage at 7 weeks with my first pregnancy. So what does that mean? That means that when Allie was pregnant, there was a little bruise that collected underneath the placenta. That bruise collected, and that is known as a subchorionic hemorrhage. My pregnancy did end up with the birth of my daughter, who is healthy, thank heavens. I never got an explanation on why it happened. Is there anything I can do to prevent this in future pregnancies? So that issue of subchorionic hemorrhage is a common finding in IVF, but it's also a common finding in pregnancy in general. 50% of normal pregnancies will have some cramping and bleeding in the first trimester. And why is that? Well, this is an easier thing to show you if I had another person here, but I don't. So I'm going to have to try to figure this out by myself. So let's say that this here, this is your uterus. Okay. The baby is in here. The blood circulates through you, goes through the placenta and on to the baby. The cervix is here. When it comes time to have the baby, the cervix has to do two things. It has to thin out, which is called effacement, and it has to dilate, right? And that's how the baby comes out. Well, as the uterus grows, the placenta, which is attached, let's say about here, the uterus is going to grow and the placenta is going to move. The placenta moves up typically as the uterine grows, as the uterus grows, and sometimes that can have a little shearing force underneath the placenta that causes that collection of blood. It's literally a bruise under the placenta, and that's what's called a subchorionic hemorrhage. If somebody punched me and I got bruised, what happens there? It's a collection of blood that's under the skin. It turns all kinds of colors. It goes from black and blue to kind of brown and yellow, and then eventually it goes away. Same thing happens to that bruise inside at the site of the placenta, but some of it probably goes out the door because that's just an easier exit. The rest of it is just resorbed into the body. Now, sometimes that bruise can keep growing. Or something, maybe you have that bruise and then you have a trauma after that, like maybe something related to sex, or you get jolted in a car accident, and that can cause that shearing force to increase, make it even worse. And when that happens, sometimes that bruise can expand to the point where it separates the placenta from the uterus. And when that happens, there's no more blood flowing to the baby, and the story's over. So that's certainly something we don't want to have happen. But the subchorionic bleed is a very common thing to happen in pregnancies in general, and it is known to be a common finding in IVF as well. Good luck, Allie. I'm so glad you had a healthy baby. Let's see here. We got some more going on. West Marie, I'm not saying it right. West Marie, maybe that's the way we say it. Going for an egg retrieval next week. So nervous to start this. Well, of course you're nervous. It's not something that you do every day. You worry about, well, what's going to happen? Is something going to hurt? Am I going to get a baby from this? This is the egg retrieval is kind of the early part of a very long road. And it's hard to predict what's going to happen down that road. And that uncertainty is absolutely disturbing. It's very normal to feel nervous about that. But on the plus side there, this is a community of people who have been through an awful lot. Take a look at the support pages for CNY, and I'll bet you will find someone who is in exactly the same shoes as you are, who can really share with you their experience, what they've been through, and what helped them get through it. This too shall pass, and there will be happy times ahead. Good luck, my friend. Let's see. Roy sells SoCal, something Southern California. Roya cell, how can one bypass a spasm in the fallopian tube? Well, now there's a good question as well, because spasm in the fallopian tube is something that usually we observe during an HSG. Have you guys had the HSG test, the hysterosalpingogram? That's the dye test that shows us the shape of the uterus and that the fallopian tubes are open. We place a little catheter inside the cervix and place some fluid inside while taking some x-ray pictures. And we see the fluid going through the fallopian tubes and spilling out into the pelvis. It is one of my least favorite things to do. I think it is probably one of the has the lowest popularity of many of the things that we do in the fertility world, because when done aggressively, it can be painful because it's distending the uterus. It can cause the uterus to spasm, and sometimes that spasm can cause the fallopian tube to appear closed when it's actually not. Did you know that in 60%, 6 out of 10 cases where an HSG tells us that the fallopian tube is blocked, the fallopian tube is actually open? That's especially true if there's just one blocked tube. So we can't ever say for sure. Fortunately, as I mentioned before, one blocked tube is pretty much as good. Having one open tube is pretty much as good as having two, just a slight decrease. But that spasm can be painful in the uterus and also can cause a false positive blocked tube on an HSG. So I'm hoping that's what you were talking about and that I was able to answer your questions. We have about 7 minutes or so left. And here's a little follow-up. Never had any infection, but my HSG came back as fallopian tubes blocked. Well, again, you had both tubes blocked there, which says, well, there's about a 40% chance that they're blocked. And so in that scenario, some of the sources recommend, well, repeat an HSG in a month. To me, that's a hard sell, because by the time you're doing that HSG, you're ready to have a baby. And so usually if we find blocked fallopian tubes, two blocked fallopian tubes, we're going to say the fastest and the most reliable pathway to pregnancy is through IVF. Let's see what else we got going on here. I got a couple more. I have noticed, this comes from CM Russo 89. I have noticed that during distance monitoring, my local clinic will say numbers to me of follicle sizes and lining thickness that is reported differently to CNY. Should I be concerned? Well, I have to say that is one of the downfalls to doing remote monitoring. I certainly think that if you have the ability to do monitoring in one of our CNY facilities, you will do better. You are closer to us. We have the information directly. Nobody is having to chase it down. Effective as the global team is for CNY, they have a lot of folks to take care of. There are fewer folks being taken care of locally because so many of our patients come from long distance to one of the CNY locations. So if you are being monitored in one of the CNY locations, by definition, there are fewer patients that our nursing team has to follow. And so your care may be you may be a little bit more individualized, and we don't have to ask those questions about, well, how accurate was the monitoring at the outside facility. Every single day, I will tell you, every single day, I will do an egg retrieval on someone who tells me that, from their monitoring, that they had 2 follicles on one side and 2 follicles on the other. And then we go and look once they're under anesthesia with the ultrasound, and they have 12 follicles on one side and 14 follicles on the other. So I don't know where some of this information is coming from. A lot of times, these remote monitoring facilities will only measure what they call the dominant follicle, meaning to say they're only measuring the largest ones. They're not measuring all of them. And in that scenario, we get faulty information. So it is a downfall, but usually what we can get is close enough that we can follow your cycle accurately and know when it is that you need to be triggered. And that's really kind of the most important thing. And then the trigger determines when are you going to have your egg retrieval. Let's see. Michelle is asking, for an endometriosis travel patient, what's mostly recommended, a frozen or a fresh transfer? I have my consultation on February the 7th. Okay, so Michelle, you know that you have endometriosis, right? And if you have endometriosis, then like we talked about before with that marker called BCL6, you may very well do better if you do 60 days of suppression directly before you do your embryo transfer. So in your scenario, without knowing anything else about the situation, I would say get your eggs as soon as you can. There's no reason to do suppression before doing an egg retrieval. Do your retrieval, get your eggs, because the earlier we get the eggs, the better off we are. But then freeze them, or make embryos, freeze them, and think about doing suppression for 60 days before doing your embryo transfer. Now, endometriosis doesn't always affect people. I think I've told this story too. I could go to do a tubal ligation on a woman who has had 5 children, and we put the camera in to tie her tubes, and oh my heavens, she is just loaded with endometriosis everywhere. I mean, how on earth did she have 5 children and she has no symptoms? She is not, she doesn't, she has no pain. How on earth does that happen? But then other people, it does affect. So we don't really know, Michelle, but I think common things being common, do a frozen transfer, do your 60 days of suppression. Couple more minutes here. Susanna asks, how much metformin do you recommend for egg quality? Rashmi asks, is metformin extended release better than the general one? And so let's just talk about that metformin thing. Metformin is a medicine that's used for folks with diabetes. It brings down their blood sugar. It's an oral medication. For people with polycystic ovarian syndrome, it helps those folks to ovulate. And in the IVF world, we use it specifically for egg quality. How much do you need? Generally, it's about 1,500 milligrams. It sometimes can be 1,000 milligrams. I dose that based upon your body weight. For folks who are a little heavier, I prefer to use the 1,500 milligrams or 2 750 milligram tablets of the extended release. I always use the extended release tablet there, Rashmi, because it has a lower side effect profile, GI things, bloating, gassy, diarrhea, sometimes nausea. And it just seems to work a little better. And it's easier to take something, kind of once a day than it is to have to take a pill 3 times a day, which is what you'd have to do with the standard release metformin. Well, it looks like we are going to run out of time here for this Thanksgiving week. And I just want to say how honored I am that you would invite me to be a part of your lives and by joining my live. How about that? Yeah, that's pretty good. I give thanks every day for all those little things, and I hope that you will find a way to appreciate them as well. As I say, fertility and infertility is not your book. It ain't your novel. It is only a chapter, and we are here to help you rewrite it. Choose kindness, choose love, choose hope, because tomorrow is a new day. Thanks for being here. Happy Thanksgiving to everyone. We'll see you next Tuesday at 4 o'clock Mountain Time, 6 o'clock on the East Coast. Till then, I'm Dr. Randy Fink. Good night.